Hey everyone, it's Mary Ann from the New York City Organization of Public Service Retirees. So I was sent another audio, this time from the retired teacher chapter meeting from yesterday, the 16th. So this little conversation is a few minutes long, and it is by retiree Barbara Waldmann. Now, I know Barbara from being on the same COMRO committee, Council of Municipal Retiree Organizations, and she and I have sparred many a times over this policy. Yet, the information that she shares in this RTC meeting on information and belief, as if she's cornered the knowledge of these facts of the Medicare Advantage plan, are absolutely incorrect, and we're going to break that down. This is important because even though she could have had a respected career as an educator in the New York City public school system, to be in a room and using the credibility of her position or stature or 20-something year retiree, the information that she is sharing as a partner within the retiree organization with Michael Mulgrew and the Unity Caucus is completely wrong. And we're going to break that down because I am tired of listening to incorrect information. Mr. Mulgrew can say that there's misinformation, but he never cites it verbatim. He will never fact check anything and provide you with evidence and documentation just like we do. And yet there's people that just blindly believe him because he's the union president. This is the problem that got all of you into this in the first place, is because none of you fact checked him, his words, his statements, anything that he's saying. And yet it keeps on coming. So this is why this is important. So let's go back to the video.
Barbara Waldmann, retiree for.
How are you?
I'm good. I'm retired for like 22 years. It's wonderful. I've been listening. I come here just about every month, and I've been listening to a lot of the discussion and argument. And I would like to just clarify some things.
Sure.
And then have a question. I think there's a lot of misinformation that goes around, and I think that people have misconceptions about the Medicare plan, the AETNA plan. And I'd like to say some things that I believe is the truth, okay? And I'd really like people to listen with open ears. And I'm going to talk the way my grandson talks to me, little Henry, who's 7. Whenever he tries to tell me something he thinks is really important, he said, "Grammy, do you know?" So I'm going to ask you if you know this, all right? But excuse me, I'm talking now.
It's not okay to be rude. I truly believe we're trying to do the right thing by protecting us in the future to do the right thing. Where I'm going to be in that place. I truly believe that that's what we're trying to get done. And I also believe that I also know that we have to build a huge apparatus inside of the union, and it will only be for UFT members. It's not for the rest of the MLC. It's to make sure that you're getting everything the right way it's supposed to happen. And that actually preserves everything that we need in terms of our healthcare. I believe that. If I stop believing that, I'm going to turn. But at the same time, guys, it's what.
And I'm almost wondering why you have to build a big apparatus within the United Federation of Teachers. You don't need any apparatus with Medicare. Medicare is such a streamlined, simple plan and the least expensive to the city of New York. And it doesn't cost the unions anything either. So I'm not quite sure why you need to build a big apparatus.
I'm hearing here is, I'm telling you. So that's it. It should not. Okay.
Let Barbara finish her question.
Yes, as I was saying, did you know that the Medicare Advantage program that's been talked about for months and months, probably more than years, the Medicare Advantage plan is not Joe Namath kind of Medicare Advantage plan. It is not one that has prior authorizations.
Okay. Boop. Big lie. Big lie. Big lie. Okay. Does it need to be the same kind of a plan, Barbara, as the Joe Namath plan? So most Medicare Advantage plans that you see advertised on TV are HMOs. We are very well aware that this is not an HMO, but this plan does have prior authorization. It actually has a lot of prior authorizations, which is why I don't understand why you're not aware of that, because they are quite prevalent. We had an affidavit done by Diane Omdahl in the Bentkowski case, actually, where she went through the entire contract. And by the way, if you ever want a copy of it, it's over 10,000 pages. Not only are there prior authorizations throughout the medical component, there's also prior authorization in the Part D drug plan. So, sorry, Barbara. Very, very wrong.
Did you know that the new Aetna plan is a PPO? That means preferred provider. Did you know that the senior care we have right now is a preferred provider program?
Actually, the GHI CBP plan for the under 65 retirees and active workers is a PPO plan. However, for the senior care supplement, which you are on, it is not a PPO. Because Medicare is primary and 99% of doctors in America, there is no network. It doesn't need to be a PPO. There is no network. As long as Medicare is accepted by the provider that you seek, and 99% of the providers in America accept Medicare, senior care must cover the last 20%. It's not a PPO, Barbara. And if you look in the GHI senior care contract, the word PPO doesn't appear. And if you want to see that, I will show it to you at the end of this.
And I can stand here. Thank God I can stand. I've had 5 joint replacements, and I have had to go to rehab. Those are the only kinds of pre-authorizations I've had under senior care. Those will be the only kind of pre-authorizations that will be under the Aetna plan.
That is wrong. So right now, I will tell you, there's prior authorization, not just in the Part D program, like I mentioned to you, but rehab, skilled nursing, hospitalization, and again, I'm going to refer you right back to Diane Omdahl's affidavit. She goes through their entire contract. There are over 10,000 CPT codes. And yet, Aetna, in waiving a portion of those for the first 2 years only in this 5.5-year contract, those can be changed, added back in. Others can be taken out, but who makes that decision? The Municipal Labor Committee, not the retirees. And right now, there's prior authorizations on so many different things. Mr. Mulgrew had even stated at one of your last RTC meetings that about 75% or 78% of the prior authorizations had been temporarily suspended. So for you to sit here and say that there's no prior authorization other than for like rehab, that's incorrect, Barbara, because there's a good 25, 30-ish, 35%, and I can't even give you an exact number because no one ever gives it. They will only give you a specific number of codes on a sheet in Appendix X in the contract. And they never give you the full amount. And that's because they can't. Because the list that they waived, that the city pays $15 a month for, to have waived that, they say about 70 to 75%, they don't even give you what they are. They only give you the CPT numbers. We had an expert go through those CPT numbers and came out that there are way more that are still left in than they want to admit to. And that is an expert testimony that we had in our litigation. So please don't tell people that there's no prior authorizations. There's plenty of them, and they're in the control of the Municipal Labor Committee that can be changed every 2 years.
And as they've said, there will be repercussions if the Aetna doesn't follow through.
And that's not entirely true either. The prior authorizations can be denied by Aetna, and actually they use a third party to review them, and they even use AI to review them. And if they are denied, there's 5 levels of appeals, Barbara. And I want to also show you the kind of penalties. It's not millions of dollars and it's not prohibitive. You'll see that some of the penalties for some of the things that they might do wrong, actually the threshold for them is quite high that they may never ever have to pay them.
I think the first pre-authorization that they expect to have, they will be fined something like $250,000.
And that's not true either. $250,000 is a very big spread, Barbara. And that is definitely not true, but I will show you the penalties after this video.
And that's because of the way, excuse me. And that's because of the way it was negotiated. So I think it's important to know that there is a difference between Medicare Advantage that you see on TV and this program that's Aetna. And, excuse me, I believe it's
Oh,
five.
wow.
It's a.
What is your question?
It's a 5-year plan, and the problem, and what I understand, did you know that the cost of medical care is escalating? And
The cost of medical care is escalating, Barbara. However, Medicare eligible retirees' costs, premiums for their plans are the least expensive to the city. Like I said, in 1965, when Medicare first came on board, the cost for the Medicare B plan, the premium was $3 a month. Today, 2024, it is only $174 a month. Our supplement in 1997, because that's as far back as I can go with rate sheets, was $88. Today, it's about $200. So the costs for a Medicare eligible retiree today are under $400 a month. Unlike an active worker or under 65 retiree, that it's about $1,000 a month for an individual and about $2,500 or $2,800 a month for family. Your Medicare eligible is the least expensive, and no, the unions don't pay for it.
this will hold the cost even for 5 years.
What's the
And so
question?
my question is, what guarantees do we have that this program, if we have to go with the Aetna, that we will have the same level of care that we have had under senior care?
Okay, so I'm going to answer this one way, but everyone, shh. So when I was down in Florida, on the trip down to Florida, I didn't do it. Somebody did it and then sent it to me. People were quoting to me Medicare Advantage issues, right? So somebody actually took down all the questions and then went back and did the research and actually called the hospitals and the facilities, and everything that was said was not true.
And yet you can't provide that here, which would be excellent. See, I make these calls on a daily basis with many different retiree organizations, whether they're in Aetna, United Healthcare, Humana, and I do these around the country. And then again, we will call and make videos to use in their litigations, and we've been right every single time. So much so that even the transit case, which is even the same contract as ours, H5522, the same contract, primarily, the only difference when their contract started in January is, and according to Aetna's sales representative, Sabrina, you know Sabrina, Mike, the only differences that was in the network were 2 hospitals, MSK and Hospital for Special Surgery. However, since our advocacy on behalf of the transit workers, MSK signed a contract for the next 3 years. That's not going to say that they're not going to stick around, or maybe they won't stick around, but that care is dependent upon contract renewal, and so is ours. Now, we also have HSS, but transit does not. And if I go around and ask some of the other retiree organizations around the country in an Aetna plan, their networks are also different. Also, when you talk to hospitals like Mayo Clinic will tell you that they do not accept any Medicare Advantage plan by Aetna, and they don't care who you are, Michael. They don't care. It's not just about the reimbursement. It's about the prior authorizations. They just don't want to do it. And that's the part you're not being genuine about. It's not just about the reimbursement. Sometimes it's about what they have to go through to get the reimbursement. or because the contract allows for retrospective reviews, that even if Aetna says that they'll cover it, they can go back later and change their mind. Doctors don't want that. So Medicare is simple. You go to the doctor wants to do a test or a procedure, it gets done. Your secondary, your supplement, your senior care, that picks up the last 20%, period. You don't have to worry about prior authorizations, referrals, denials, none of this. It doesn't happen. So Barbara, I know you were planted in the audience to make this question because your questions, you know for a fact, I know you know that they're not true. You and I have had these conversations before. And to have heard you argue at the city council hearing last year that you wanted to pay for your senior care, you weren't saying, oh yes, Michael, put me in the Medicare Advantage plan. You wanted your senior care and you wanted the choice to be able to pay for it. God bless you, because not everybody makes a $75,000 pension or $80,000 pension, my dear. So I have to look out for everybody. And it's really a shame that someone can sit here in a room full of retirees in some invulnerable situations in dealing with cancers and listen to you say that there's no prior authorization and the plan is just as good as Medicare, because it's not. And it doesn't have anything to do with it being a PPO, not a PPO, or even it's not like Joe Namath's plan. Medicare Advantage plans, all Medicare Advantage plans operate the same way. They have prior authorizations and a network, and Medicare Traditional does not. Medicare Traditional has rare prior authorization, unlike the plan that your boss is trying to put us into, Barbara.
Okay, first. But this is what I have to tell you. Stop. You cannot compare this to anything because nothing. There is nothing like this that has ever been in existence in the history of the United States. This plan is absolutely different. It is more of a PPO than a Medicare Advantage plan, but it.
And all PPO means is that it is a preferred provider organization. You have a network. Medicare doesn't have a network. It's not a PPO. It doesn't need to be. There's no network. Basically, you're saying you have a network of providers to use, that you could use the preferred ones, but you could also use the non-preferred ones. You're going to pay for it. There's other paperwork, administrative procedures involved, like pre-visit confirmations that the doctor doesn't do, but you as the retiree has to do. But if you use the preferred providers, you don't have to do that. The provider then has to do the prior authorization. Come on. This is where this gets confusing to most people, but you're not going to confuse me. I would love to sit in a room with you, Barbara, and you, Michael, and go through this on a stage with the three of us with my laptop, and you prove everything that you think is a fact, because I have not seen anything come out of either one of you to support evidentiary-wise anything that you're saying. Yet video after video, I can bring up the contract, I can bring up documents, I can bring up governmental citations, and yet you guys are the educators.
It has to be called Medicare Advantage because that's what qualifies for the government subsidy, which lowers our healthcare costs and allows us to keep it for a longer period of time. There is no Medicare Advantage plan in the world that has only very few prior authorizations. That's this one. But you keep comparing it to something and causing fear and anxiety among people.
It does exist, Mike, and it's not very few. And even when you guys fudge your numbers and say it's 72% were suspended, 75% were suspended, 25% is still a lot. So hypothetically, let's just take an idea of what that looks like. There's well over 10,000 CPT codes. Times 25%, my dear, is 2,500 different CPT codes. That's still a lot.
People, because you keep comparing it to things that are in existence now when this has never been in existence. And we looked at those plans specifically that you're talking about, and we negotiated that way. You have to understand, the city actually negotiated the plan and brought it to us for approval, and we said absolutely not. We're not approving it because there's too many things in here that we don't like, that we did our homework on Medicare Advantage plan. And we have our own set of doctors who would look at that. We're gonna run it like our welfare fund. I'm not telling you that's for all city workers. I'm just telling you, we are doing that for you. Just like our welfare fund, when we check everything for you, and if there's a problem, we call the doctors, we do the things, we call the insurance company. That is the whole idea behind it. So please stop comparing it to existing Medicare Advantage plans, because it does not, okay?
Not really, Mike. Not really, but I do want to show you some of the documents. That way, you can see that some of the things that Barbara said are not really the truth. So let's go to the contract. So here's the contract. And as you can see, this is 10,474 pages. And this contract is between the New York City Office of Labor Relations and Aetna. So some of the things I want to show you is that the city the Aetna actually has to provide reports on prior authorization approvals and denials. So, dear Barbara, if there are no prior authorizations, why do they have to provide a report on that? So there actually are prior authorizations. So that is one step right there that I could show you. This is performance guidelines. Now, so you had said that there would be $1,000, $1 million worth of fines. Let's start looking at what these fines are. So here, quarterly, Aetna will share tracking reports. So if reports aren't given to the city or the MLC based on risk scores and accuracy and adequate reimbursement, $570,000 divided quarterly is what they would have. This has to do with account management and team effectiveness, their average scoring, how they have certain benchmarks. Again, $570,000. This is not a lot of money. Communications. Aetna on a quarterly account team will bring innovative products and opportunities to OLR and the MLC for discussion and consideration. If they don't, $570,000. This is not benchmarking, my dear. Timely and accurate submission of required data. Pharmacy retail paper claims, $114,000, which is 1% of the actual turnaround time. This is not a lot of money. Pharmacy mail order dispensing accuracy. If there's a problem, a penalty of $114,166 will apply for each 1%, that the actual percentage of all mail order prescription dispensing. So here, your total risk for all of that would be $9 million. And that's if you did every one of those things wrong. Chances are they're not going to do every single one of those things wrong. And then this still shows that this guarantee period will expire now, the end of the month, the end of the year. Aggregate maximum. In total, Aetna agrees to place $7 million at risk for the implementation guarantee, $9 million for the plan year, and thereafter through the performance guarantees, both the document. For both the implementation and ongoing performance guarantees, if less than 80% of the 250,000 eligible members enroll as of January 1st of 2024, Aetna will prorate the actual risk amount. Now, remind you, 250,000 eligible retirees isn't what was in the city. As of like one of the last reports, it was like 183,000 people. And those are their penalties. Now, we talked about prior authorizations. Attachment H is prior authorization waiver list. Well, if there weren't any still left to be waived, then you wouldn't need a list of those that were waived. Well, this is all that's waived, Barbara. That is all. Which means there's a whole bunch more that are still in there. And that's all you have. Let's make that smaller so you could appreciate what that is. That's it. There's over 10,000 CPT codes. Does this look anywhere near 10,000? No. So I'm sorry, Barbara, there's plenty of prior authorizations. Now, you want to talk drugs. There's prior authorizations on drugs, just like I told you. And those are here. Specialty drugs subject to prior authorization. You want me to keep scrolling? And I could be here all day because it's a huge document. The point is that this plan is not what you think it is. It's not what he says it is. It's not what you're saying. And facts matter, Barbara and Michael, and it's important that you tell the truth. So I think I've showed you again that you're spreading misinformation. This 10,400 page document shows that you're not being honest. There's prior authorization. There's 5 stages of appeals for denials. These are not things that we have in traditional Medicare. You have rare prior authorization for things like motorized durable medical goods or cosmetics procedures. Sorry to break the bad news to you, but you're sharing misinformation yet one more time and trying to sound like an expert. Please cite and source everything that you say to back it up, because I no longer believe you at all. Please back up everything that you say, because it's important what you say that people can believe you. We back up everything we say. Anytime, Barbara. Whether it's here, in Comro, you want to pick up the phone, but please stop lying to the retirees of the city of New York. Have a good night.